So excited to welcome on Meg Smith. Now, Meg is the PGY2 critical care pharmacy resident at SSM Health, St. Louis University Hospital. Welcome, Meg. Thanks for joining. How are you?
Thanks for having me. I am great. How are you?
I'm doing great. We got to say it. So we hopped on the Zoom, and the first thing I shouted out was like, "Wow, your backdrop is impressive." So let the audience in. Is this it's instead of the cake video, we're gonna do the Zoom background video. Is this real or fake?
Yeah, that's a great point. It actually is fake. It fooled a lot of my online interviewers. So I actually just found it on just a regular Google search. I thought it looked great. There, I have been asked about things in the background before. I have no idea what they are. So sometimes I just have
Oh,
to,
they ask you what kind of plants they are. They're like, "Oh, what
yes.
is that in the background?" sort of thing.
I do love plants, so I have a lot of plants, but they are maybe not this healthy sometimes. So,
Hey, they thrive, They
Mhm.
everyone plants go through ups and downs just like we do, right? They don't get the perfect amount of time. But yeah, I had to point that out because we hopped on and I was like, wait, I can't actually tell. So strong work, especially in the digital world, to have something as good as that. But of course, the real reason we are here today. So, a therapy that is a cornerstone in one area, but sometimes feels like it's continued indefinitely in the other. I'm excited for Meg to untie this web of using a famous drug in a very acutely ill disease state. So, take it away.
Yeah, so I'll be presenting on N-Acetylcysteine and non-acetaminophen induced acute liver failure. And first, I wanted to start off with what is acute liver failure or ALF? It was first described in the 1970s as a fulminant liver failure in the absence of pre-existing liver disease. They thought of it as a potentially reversible condition secondary to severe liver injury. They also defined it as the onset of encephalopathy within 8 weeks of the first symptoms, which were typically jaundice. This is similar to the 2023 American Journal of Gastroenterology guidelines for acute liver failure. They're defining ALF as a life-threatening condition occurring in adult patients with no pre-existing liver disease. However, they also note abnormal liver tests, coagulopathy, which they define as an INR greater than 1.5, hepatic encephalopathy, which is described by the West Haven criteria, as coma grades of 1 being classified as less severe and coma grades of 4 being classified as most severe. And then most importantly, this duration of less than 26 weeks. The 2017 European Association for the Study of the Liver also have a very similar definition. Although I do want to point out some differences, they do include prolongation of prothrombin time, and there's a slight variation in the overall timeline. For example, their duration is actually less than 28 weeks. I do want to point out that it is important to note that acute liver failure is different from acute on chronic liver failure, as they're commonly misinterpreted as being the same despite having different treatment recommendations. Acute on chronic liver failure is described as an acute deterioration in liver function in patients who already have pre-existing chronic liver disease. So just for the purposes of this presentation, we're going to be focusing on acute liver failure. The management of acute liver failure per the 2023 American Journal of Gastroenterology guidelines really focuses on identifying the cause and implementing an etiology-specific management if it's established. The most common etiology in developed countries is typically drug-induced with things like acetaminophen, and the most common etiology in countries that are developing are typically viral. When we're thinking about other treatment strategies for these patients, we're really kind of limited to supportive care. All of these patients will have some form of hepatic encephalopathy, which there are guideline recommendations for their support. And some patients will have some type of hemodynamic dysregulation, which could require support with fluid or pressors. Really, our shining therapy option for this disease state is liver transplant. Patients with ALF receive the highest listing on the donor list of status 1A for transplantation, as this is really one of the only treatment modalities that's going to impact mortality. So much so that overall mortality within 3 months is around 47%. And in patients with liver transplants, their 1 year mortality is actually decreased to 20%. So that's a huge decrease. Liver transplants are so important in these patients. There are, however, limited treatment modalities for acute liver failure that have proven benefit. And for this reason, therapies like N-Acetylcysteine or NAC have been studied to help discover potential treatment options that can help decrease this high mortality rate that we're seeing with this condition. So what is N-acetylcysteine? It's cleverly named. N-acetylcysteine is the N-acetyl derivative of the amino acid cysteine. It was first utilized in medical management in the early 1960s, originally as a mucolytic agent. In the 1970s, NAC became commonly used in acetaminophen-induced liver failure. This was after clinical trials came out that confirmed its efficacy in preventing liver damage, renal failure, and even death. The pathophysiology of acetaminophen-induced ALF is the accumulation of NAPQI, which normally is metabolized by glutathione. After high doses of acetaminophen are ingested, glutathione stores are depleted and NAPQI will build up and become responsible for hepatocellular necrosis. The mechanism of action of NAC is that it's going to restore this hepatic glutathione and by serving as a glutathione substitute and enhances the non-toxic sulfate conjugation of acetaminophen. It really wasn't until the 1990s that there were a handful of studies published that investigated the potential mechanism of action for NAC and non-acetaminophen-induced ALF. There was a publication in the 2004 Annals of Pharmacotherapy by Schuyler and colleagues, and they summarized this early literature and concluded that there are potential microvascular regional benefits such as improved oxygenation and mitochondrial function in liver cells that can be gained from IV acetylcysteine administration in patients with non-acetaminophen-induced ALF. However, all of these studies were pretty limited by the fact that they really didn't investigate clinical outcomes like mortality. So that's something that we wanted to look at going forward. What is the pathophysiology of non-acetaminophen-induced ALF? It's really suspected that ALF is caused by some sort of oxidative injury, which can lead to hepatocellular apoptosis and mitochondrial failure. There's also thought to be an element of tissue hypoxia. So the mechanism of action that were identified by a lot of these early studies is that NAC is acting as an antioxidant beyond just being a precursor to glutathione, similar to how it's used in acetaminophen-induced ALF. It's thought to do this through sulfate and sulfur species, which can scavenge for free radicals. There have also been some mouse models that found that NAC can improve mitochondrial dysfunction and exhibit an anti-inflammatory effect by inhibiting activation of toll-like receptors and lowering systemic cytokine levels. This has also been found to normalize cerebral edema and decrease neutrophil infiltration into the liver. There are some studies that suggest NAC can improve oxygen delivery and consumption, potentially due to a cyclic GMP-induced vasodilation. However, these have not always been reproducible. I do want to take a brief moment to talk about some considerations for adverse reactions. So the one that we're kind of the most concerned about would be the non-immune anaphylaxis. This can range from mild symptoms like skin rash, flushing, to more serious bronchospasm, angioedema, hypotension, which could be fatal. Typically, this will present with 1 to 6 hours after administration, but have been reported up to 24 hours. Other common adverse reactions are things like nausea, vomiting, GI upset, and fever. So going back into the literature, in 2009, our first randomized control trial was published in Gastroenterology by Lee and colleagues. They were comparing IV NAC to placebo and 4 common causes of acute liver failure: drug-induced liver failure, autoimmune hepatitis, hepatitis B, and indeterminate causes. They had 81 patients in the NAC group versus 92 patients in the placebo group. And overall, they found no differences in overall survival at 3 weeks. This was 70% in the NAC group versus 66% in the placebo group. However, transplant-free survival was significantly better for N-acetylcysteine patients versus placebo. This was 40% versus 27%. I do want to point out that this was really only seen in the 114 patients with the lower West Haven criteria coma grades of 1 to 2. When then we're talking about ADRs and adverse effects from this trial, only nausea and vomiting were occurring significantly more frequently in the NAC group compared to the placebo. This was around 14% versus 4%. Based on all these findings, The authors concluded that IV NAC can improve transplant-free survival in patients with early stages of non-acetaminophen-induced ALF. However, there was no perceived benefit in patients with advanced coma grades with the West Haven criteria of 3 to 4. I do want to point out a limitation of this trial is that they used one-sided p-values. There was actually another study group that came along later that reanalyzed this data using two-sided p-values, and they really could not replicate the statistical significance found in the original findings. The next randomized control trial I want to talk about was published in 2015 in the Saudi Journal of Gastroenterology by Nabi and colleagues. This was another prospective randomized control trial comparing IV NAC to placebo in ALF in patients with undetermined etiology, drug-induced liver injury, or viral causes. They had 40 patients in the NAC group and 40 patients in the placebo group. And what they found was that NAC had an improved in-hospital survival. This was 72% in the NAC group versus 47.5% in the placebo group. However, when they stratified this out by etiology, it was really drug-induced liver injury that retained slightly superior outcomes with NAC. They also noted that NAC was associated with a shorter length of hospital stay in survived patients. And interestingly enough, they identified some predictors of mortality, and they found that these were things like treatment with N-Acetylcysteine, their West Haven criteria grade, so if they had the lower grade of 1 to 2, age greater than 60, and if they had ascites present. Another thing that this study found was that there were no adverse effects reported that could be attributed to NAC. Based on all these findings, they recommend that NAC alongside conventional therapies be used in non-acetaminophen-induced ALF in non-transplant centers while awaiting referrals, and they concluded that NAC was safe. I do want to point out another limitation in this study is that the study site was not able to confirm acetaminophen exposure via blood test. They were really limited by using their past medical history and other signs and symptoms that could point to acetaminophen-induced ALF. And then wrapping up our literature with a 2022 meta-analysis published in the Polish Gastroenterology Review by Amjad and colleagues. This included 5 studies, including the 2 randomized controlled trials we just talked about, and then 3 observational studies. When combining all of this data together, they found that the overall survival was 70% in the NAC group versus around 60% in the control group. They also found that the transplant-free survival was improved by 44% in the NAC group, and that NAC significantly reduced the duration of hospital stay. The common adverse events in the NAC group were similar to how we talked about earlier. It was things like nausea, vomiting, dyspepsia, fever, rash, infection, arrhythmias, and then rarely bronchospasms. But they do want to note that the adverse effects were not statistically significant compared to control groups in most of these studies. Based on these findings, the authors concluded that NAC demonstrated improved transplant-free survival and duration of hospital stay in adult populations with non-acetaminophen-induced ALF. However, the improvement in overall mortality was not statistically significant, and they concluded that more research is required to identify the true role of NAC in non-acetaminophen-induced ALF. So my conclusions based on all this literature, there are some limitations with these studies, but the overall trend is that NAC may be associated with improved transplant-free survival, and it has relatively low adverse effects associated with, and it may warrant potential use in patients with limited treatment options. I think the key takeaway is that if implementing this in patients with the lower coma grades of 1 to 2 may have a higher benefit. So what are the guidelines recommending for this? The 2017 American Gastroenterological Association Institute Guidelines for the Diagnosis and Management of Acute Liver Failure actually recommend that NAC only be used in the context of clinical trials. This is different from the 2023 American Gastroenterology Association guidelines, which suggest that IV NAC be used in patients with non-acetaminophen-induced ALF, and they are specifically referencing this literature that supports it in early use with coma grades of 1 to 2, and it's having an effect on transplant-free survival. And then interestingly enough, the 2017 European Association Study of the Liver recommends NAC as standard of care in early stages, even in non-acetaminophen-induced cases. So we know the studies, we know the guidelines, but how do we dose this medication? I feel like that's always a common conversation that we're having regarding N-acetylcysteine. The biggest difference between dosing strategies from acetaminophen-induced acute liver failure and non-acetaminophen-induced liver failure is the overall duration. Non-acetaminophen-induced liver toxicity, we really don't have any dose-finding studies that help us determine this, but the randomized control trials both use the same method. They'll have a loading dose of 150 milligrams per kilogram for an hour, followed by 12.5 milligram per kilogram for 4 hours, and then 6.25 milligram per kilogram per hour for 67 hours, bringing home a total duration of 72 hours. However, in practice, this will probably be continued on for longer. This is different from the acetaminophen-induced liver toxicity, where the total duration is typically more of around 21 hours. So the question on everybody's mind is, how much does this cost? For a 20 milligram per 30 ml vial, the average wholesale cost is around $72. So if we're looking at the 72-hour duration method, a total cost for an 80 kilogram patient will be around $600. And so that's something to keep in mind. So wrapping it up, bringing it all home, what are the arguments for using this medication versus the arguments against using this medication? Arguments for, there is a suggested benefit in these early stages of ALF that we see in the literature. However, an argument against would be that these benefits are not clear and unequivocal. So what effect is it really having on these patients? Another argument for is that it has a relatively good overall safety profile. The most common symptoms that we're seeing with this medication are things like nausea, vomiting. However, an argument against is that there really are some serious adverse reactions with this angioedema anaphylactoid-like reaction. And is this worth it in a medication that might not be providing that much benefit? Another argument for is that compared to transplant, $600 for a total duration of N-acetylcysteine is pretty reasonable cost. However, again, an argument against is that we're not sure if this medication is having that much effect. So $600 in that context is kind of a lot if this is not having a clear cost-benefit relationship. And then another argument for is it's relatively easy to administer. Overall, N-acetylcysteine's true clinical effect in non-acetaminophen-induced ALF is difficult to ascertain due to limitations in the literature. However, data suggests that early treatment may improve mortality and hospital length of stay. Given the paucity of treatment options impacting mortality for this disease state, utilizing NAC can be considered, especially since it's a relatively safe medication. And that's all I have.
Okay, that was a great review of the actual data that we have supporting what I would say is probably a fairly common practice. All right, so you mentioned at the end that we can utilize it. All right, so I know you reviewed tons of literature, guidelines. You got into the Americans versus European battles. So in your opinion, do you think the benefits from those studies outweigh the arguments which are against its use, which are essentially cost and drug utilization? What do you, in your opinion, what do you think?
In my opinion, we really are limited in our options here. And so, what's the harm in trying this medication? Just making sure we're monitoring these patients for that potential anaphylactoid reaction in the first 24 hours. And I think that it's definitely worth giving a try.
Yeah, I completely agree. And if for those who feel like, the knack is on forever and ever, I think utilizing some of the same labs and strategies that you do for Tylenol induced liver failure, you're looking for LFTs, INR, encephalopathy, those sorts of things to kind of track it and things. I have the same thoughts that you do. And going through all of this, wow, was that illuminating. I feel like you really created a gateway of understanding for us for NAC with Tylenol induced liver failure and kind of differentiating that in talking about our non-Tylenol induced liver failure. So Meg, thank you so much. Let the listeners know, where can they reach out to you and tell you what an awesome job you did.
Oh, yeah, you can reach out to me at my email. I don't know. I really don't have a good way to reach out to me because I'm not on social media.
Okay, so Meg is too cool. So reach out to me and I will pass on the comments of it. But Meg, thanks again. This was awesome. Appreciate you.